We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, I'm Dr. George Kosmadakis, nephrologist, and I'm your today's host for the ERA podcast, A Pinch of Salt. Uremic pruritus is one of the subjects that a lot of us think that it is not an issue. Nevertheless, it is one of the most important problems declared by the patients in the quality of life surveys. Additionally, it seems that it is seriously underdiagnosed and therefore seriously undertreated. Newer elements have come to surface concerning the pathophysiology and the treatment of uremic pruritus, and today we have the honor and the pleasure to discuss about them with Dr. Antoine Lanot, nephrologist from the University Hospital of Caen in Normandy, France. He is a known specialist with a series of review articles and studies on this subject. Antoine, thank you for joining us today in the Pitch of Salt.
Well, thank you very much for inviting me, George. It's a pleasure.
So, Antoine, I know that we have a lot of questions to answer and not a lot of time, so I will start straight away with the obvious question. How can somebody define the uremic pruritus?
Well, uremic pruritus was first described in the 19th century by a French professor, Georges Dieulafoy, and he has long been recognized as a distressing symptom. So Dieulafoy noted that unbearable itching was indicative of what he called small uremia at this time. And over a century later, the preferred term for this condition is CKD-associated pruritus, CKD-AP. So it manifests as chronic itchiness lasting more than 6 weeks, stemming from kidney disease and not attributable to any other cause. So CKD-AP can occur in individuals with advanced CKD or those undergoing dialysis treatment.
Right. So we shouldn't call it uremic pruritus. It's called CKD-associated pruritus nowadays. That's the correct definition, the correct term. And I'm discussing with several colleagues, and very often they come with, they are puffing, and they say, "Oh, it's not a problem anymore." I tell them, I'm not so sure. What do you think? How big is the problem of CKD-associated pruritus? Are there a lot of underdiagnosed patients?
Yes, there are. CKD-AP is a common condition. It has been shown that moderate to severe pruritus was affecting 25 to 50% of hemodialysis patients.
Wow, half of the patients.
Yes, probably, if you do a systematic screening. However, it remains an underestimated diagnosis. And according to a DOPS study published in 2017, there were 17% of patients in HD who were significantly bothered by itching and who did never disclose this symptom to any of the healthcare staff. 17%.
17% that had a problem, but they did not consider that it concerns their kidney disease.
Yes, while they were seeing nephrologists 3 times a week.
Right.
And on the other side, in the US, a study revealed that 69% of the medical directors of HD units, they underestimated the prevalence of pruritus within their own facilities.
So it's not only Europe, it's also in United States.
Yes,
the problem.
Worldwide. So it's under-recognized by healthcare providers, and it's underreported by the affected patients. So I think this should convince us that we need to make a systematic screening of the symptom, especially in hemodialysis patients.
Of course, if you don't search, you don't find, and we should search. It's very important. It's very important. So I think there are some newer conceptions concerning the pathophysiological mechanisms of CKD-associated pruritus. Could you explain us in a few words what's going on with the mechanism? Why people are itching?
Yes, it's a big complex, and the pathophysiology is intricate. Right now, our understanding has advanced in the recent decades, and currently 4 axes are believed to contribute to the pruritus in CKD-AP. The first axis revolves around uremia. Uremic toxins accumulate in the plasma of CKD patients, and it has been suggested that some of these toxins could precipitate as crystal in the skin, acting
Right.
as pruritogens. However, it is notable that no such crystals have been identified in skin biopsies. And we always talk about phosphorus, but in big DOPS surveys, no correlation at all was found between pruritus and
And
any
phosphate.
calcic metabolism process.
Right.
So this is debated, this uremic axis. The second axis involves peripheral neuropathy. And there is a specific pathway, which is not like for allergies, the histamine pathways, which has been identified. One of the pathway is called the CoH pathways, and it would mediate the itch signal in CKD-AP. So current research indicates that this pathway and some others are upregulated and overactivated in CKD-AP. The third axis is about opioid receptors, kappa and mu, and these receptors are located on nerve fibers, with mu receptors who are promoting itchiness and kappa receptors which are acting as antipruritogens. In CKD, there exists an imbalance favoring mu receptors over kappa receptors. And finally, the fourth axis implicates the immune system, with opioid receptors kappa and mu, which are present on various immune cells. And the predominance of mu receptors leads to an activation of these cells toward a Th1 profile, fostering then a pro-inflammatory state. Consequently, this results in the release of numerous cytokines known to stimulate itch receptors.
So it is a complex entity with various pathophysiological mechanisms, immunological, opioid receptors, CoH, inflammatory. So we are not sure which of these 4 mechanisms is the main mechanism for pruritus, but I didn't hear anything about histamine.
Exactly. Histamine has been shown to have nothing to do with CKD-AP.
Right. So all these years that we were prescribing antihistaminic treatment, it was a little bit of a placebo treatment, I suppose.
Probably, but perhaps it could have a tiny role, and we will probably speak about it
later. Okay. Yeah. Yeah. Well, you said that it is underdiagnosed, and we should take measures to diagnose it. But how can we correctly diagnose CKD-associated pruritus? Which are the proper diagnostic tools today?
Well, we have to be cautious about diagnosis, and first, we should not forget that CKD-AP is a diagnosis of elimination.
Right.
So first, we have to seek for classic causes of itch: allergy, infections, lymphoma, cholestasis, maybe drugs, to name a few of these causes. And after the exclusion of other causes of pruritus, then we can say it is a CKD-AP.
So
And
we should exclude any secondary cause of pruritus, any common cause of pruritus. Okay,
Exactly. And this is not so easy.
of course.
After that, when we think that our patient has CKD-AP, we can use a scale to assess the itch severity. The most commonly used scale right now is the WINRS scale, which means Worst Itching Numerical Rate Scaling. And it consists in asking the patient to note the intensity of his worst itch from 0 to 10. So it's quite easy to use in practice. And then it's important to assess the itch-related quality of life. And there are several validated scores which exist, like, for example, the Skindex-10 or the 5D itch scale, or the simpler self-assessed disease severity, for example. So we have these two elements, the intensity and the quality of life, and we have to assess both of them.
Right. So if I want to know in my dialysis unit whether there is a problem of CKD-associated pruritus, I should start with the WIN scale.
Exactly.
Okay, validated in all languages,
Yes.
in your European known languages, I suppose. And I should for sure continue with the quality of life associated questionnaire like Skindex or the 5D scale.
Probably it's taking a bit of time, and you can also talk with the patient when you identify them as having itch, then talking about several aspects of or domains of quality of life, and especially the sleeping disturbance, because this is one of the main problem of quality of life about pruritus.
We will have, I think, a podcast concerning the sleep disorders in CKD. It's a very important issue. And so do you think that we should start with WIN scale and after, for those who are positive, continue with the quality of life questionnaire, or everybody should answer both questionnaires?
In a perfect world,
Perfect
everybody,
word, yeah.
but it's taking time to make those quality of life questionnaires. So probably only for those who have a WINRS scale of 4 or plus.
Doc over 4, doc 4 or more than 4. Okay. So, ladies and gentlemen, you heard the man, the specialist. There is this questionnaire, and you can be confident that you can find the patients who do not make the association between pruritus and the kidney disease. And so we pass to the next obvious question, Antoine. Which are the treatment options today? Should we continue prescribing antihistaminic drugs to the patients?
The question remains
Debated.
yes, well, it's not evident from a pathophysiological point of view, but I think first, every CKD-AP patient should benefit from general measures. We should prescribe moisturizers twice daily, and this is essential to address the common occurrence of xerosis, which is very common in CKD patients. And subsequently, dialysis adequacy should be assessed, and dialysis-related measures should be considered, like using high flux membrane. I think we use this every part in Europe right now, but this has been shown to be beneficial to CKD-AP patients. Maybe we can explore more biocompatible membrane for a given time, trying for 1 month, for example. And we should, of course, assess factors such as KT/V, phosphocalcic metabolism products, or iron levels, although the benefits of few of these interventions have been definitively established. And secondly, for the patients who experience moderate to severe pruritus, which is WINRS of 4 or more, for those patients, we should consider specific treatments. Some authors suggest conducting a therapeutic trial with non-sedative antihistamines for 10 to 15 days. Why? Because it should not work in CKD-AP, but given that the diagnosis is not so easy and there are lots of alternative diagnoses, if antihistamines is efficient, then it's good for the patient, and maybe it's not CKD-AP, but we have a clue for considering other diagnoses. So why not to try antihistamines for 10 to 15 days? And then if it's not efficient and it's a CKD-AP, we have several off-label treatments which have been investigated. For example, UVB phototherapy or selective serotonin reuptake inhibitors, but the results are conflicting with those. We have, on the other side, gabapentinoids, which have demonstrated efficacy in 4 small RCT, but they are off-label and with a narrow therapeutic window and potential side effects. So be cautious with their use. Right now, the only approved medication for CKD-AP in hemodialysis is difelikefalin, which is an agonist of kappa opioid receptors. It is administered 3 times a week at the end of HD sessions, and it has been approved in both Europe and the US from 2 international RCTs.
Right. So you suggest that we should start, like always, with the general measures,
Yes.
dialyze well the patients, be sure that all the elements of dialysis are correct concerning efficacy and bone disease measures. You suggest that we should absolutely offer emollients and hydratants for the skin, for the cirrhosis of the patients, and try potentially an antihistaminic therapy for a few weeks. And if all these measures are not efficient, then we should pass to a medical treatment with UVBs, gabapentinoids, SRSAs potentially. Everything is off-label. And finally, if we cannot find any solution, any efficacy, try difelikefalin for those countries where it is circulating. I have a personal experience with some patients when we were really desperate, and it was efficient for them. I don't know if it was the medication that was efficient or the fact that we told them that this is the last solution we have to offer to you. It's the best medication, etc., etc., etc. But I didn't dare to give them saline instead of medication to see if it will work.
But if you have no economic limitation and it's available, I would advise to use difelikefalin prior to UVB phototherapy or gabapentinoid because they are off-label. Whether
They are off-label, of course. This is the only one that has a real indication. So perfect. Thank you so much, Antoine. And now we will ask you the 2 typical questions we ask all our guests. And these are, if you were in a desert island, can you name a book, a luxury item, and 2 songs you would take with you?
This is quite difficult.
I know. It's the most difficult question for everybody.
Yes. Maybe for the book, I would cheat and choose the complete works of Shakespeare.
Oh.
So I would have a lot to read.
In the original?
No, in French.
No. Should be reasonable.
I don't know if it's a luxury item, but maybe I would choose a guitar so I could spend hours learning how to play it.
Wonderful.
And 2 songs, maybe a modern Anikuni by a band named Polo and Pan, and a more classic song, Toccata and Fugue in D minor by John Sebastian Bach.
Oh, wonderful. I think you are between the only guests who proposed the classical music piece. Wonderful. Now, you come from Caen in Normandy, and I would like it if you could tell us a few words about your town, please.
To say it short, so Caen is a very nice city from northwestern France. This is close to the sea, where the Allies have landed on 6th of June 1944. And it is the city of Guillaume the Conqueror, which is the only man who has been able to conquer England in all the history. And it is the only French city whose football club is named after a poet, Malherbe.
Wonderful. So William the Conqueror is coming from there, and so Antoine Lanot is a descendant of this big tradition. So that was wonderful. Dear colleagues, so I hope you found this chat on CKD-associated pruritus as interesting as I found it today. I also hope that it clarified some issues that were not absolutely clear for you, just like me. Please do not hesitate to listen to the past and future podcasts, A Pinch of Salt. Check us out.